Hi, everyone. Welcome to the broadcast tonight. We're going to talk about Lyme disease and chronic infections, specifically some of the obstacles that I see when antibiotics are failing. My name is Dr. Shaun Riddle. I'm a naturopathic doctor out in Calgary, Alberta. And we are, if you haven't heard, we're getting inundated with the smoke from all the BC fires, probably a lot like the folks out in California. In any event, if you guys have a chat function, as I understand, and if anyone has any questions or comments, please don't hesitate to type those in. If it's getting really a high volume of that, we'll probably save them for the end. But if there's not, then I'll try and address them as they come. Okay, so why don't we get started? So just a little bit about my background. I attended naturopathic medical school in Seattle, graduated in 2003. I spent the majority of the 2000s traveling back and forth from Canada to Switzerland and to Germany. And anytime we would hear about some doctor who was specializing in biological medicine, we would rent that person out. So we would head over there and learn as much as we can. So that's my background in the biological medicine arena. In the early 2000s, I went out to New York State and did my lab physician's training program. I worked with Dr. Richard Horowitz. And then just in the past, I did a master's in teaching and secondary science and a bachelor of science in biology, in cancer research and model. A little bit about where I'm coming from in terms of practice evolution. When I first got out, I was really interested in physical injuries, and I was treating a lot of pain, myofascial dysfunction with therapies, things like prolotherapy, which, if you don't know, is a dextrose-based injection. There's a step up to that, which utilizes ozone as well. And then most people have heard of the PRP, the platelet-rich plasma injections. But my personality is such that I got really interested in the percentage of people that weren't responding to it. Because when the people that did respond to it responded so greatly, I was really curious about why people weren't responding to Prolo. And I landed on adrenal insufficiencies. Sometimes there were some hormone issues, some mineral imbalances. But there were a couple people who had some really strange pain patterns that didn't seem to match, typical neurologic patterns or myofascial patterns. And I threw up a Hail Mary in a couple of those folks and ran a test through the company Igenics out of California. And sure enough, both of those patients came back with Borrelia and Bartonella infections. And at that point in time, I knew enough to know that there was an issue there, but I had no idea what to do with that. So that's when I started, I went out to New York and did my ILADS training. So before we dive into the presentation, I'll just kind of state some of the goals. There's a lot of different ways of organizing these obstacles that people run into that prevent them from getting better with this condition. I want to describe some of the ones that I think are the biggest things that I see. There are quite a few that have come and gone, right? But might not really have a major impact in the majority of patients. So either won't mention those or will minimally mention those. But I'm really focused on the ones that have made a huge difference in my patients. Maybe we'll talk about a few things that you might not have heard of before, or that you might be, just be casually aware of, and might stimulate you to look into those deeper. So I'm hoping that that'll happen as well. I also want to, really focus on the fact that people seem to be really individual in terms of their, reactivity to these bugs, also their terrain issues, their individual terrain issues, and we're going to talk about what that means for those that don't know what that means. And for some people, I spoke with a patient a couple of days ago who believes that that his diet change was got rid of 80% of his Lyme symptoms, right? And sometimes I know for some of us who are practitioners, it's easy to get into the details and the minutia of some of the more sort of maybe more exciting types of things, like mold and biotoxin issues and things like that. But sometimes it's just diet. So we'll look a little bit at that. I'm also going to speak to some of the technological limitations that I see with some of our testing. I think that's one of our biggest issues with this syndrome is that we don't have great, in some cases, we don't have really great black and white tests. And so I've written down here, is there a place for energetic testing? So when I when I first began in biological medicine, I did quite a bit of EAV testing. And when I started, when Lyme patients started seeing me more and more, I put that equipment away. And I felt like we were opening up a Pandora's box for a lot of people with that diagnosis. And I wanted to be as black and white as I could. I wanted to be, to have test results that we could sort of grab onto. And so, I've got several machines that are gathering dust in my garage right now. But, I'm now starting to think about, you're going to see in this next point, for instance, this retrovirus issue that's starting to come up. Energetic testing might be the only way that we're going to be starting to identify those kinds of things. So I'm starting to revisit that personally in my own practice. And then I'd like to highlight some new areas of interest that might bear fruit. And this is the retrovirus activation is coming out of Clean Heart's working group as well, where he's starting to think about Lyme is activating retroviruses, and that might be the biggest sort of linchpin in this issue. So, in any event, those are the things I'd like to hopefully address for everybody. Okay, so Lyme disease, and I've got a question mark here because, at least in my, I'm sure if you're in the northwest of the U.S. Or even in the eastern part of Canada, many medical professionals are a little bit more conversant with the term Lyme disease. But in my part of the country, doctors know Lyme disease as a Borrelia burgdorferi infection only. And when I talk about Lyme disease, and oftentimes when patients are reading about Lyme disease online, people use that term to mean a whole variety of infections. And sometimes we classify those as co-infections. And I've listed sort of the major co-infections that we can test for here, including some viruses and the parasites. I haven't listed the parasites here, but I think it's really important to understand when you're talking to a medical professional what definition they're using. So I want everyone to be aware of that. The first line of this slide is, do we have a Bartonella problem with a Lyme co-infection? And is this just semantics? I don't think so, because I think, those have different implications in terms of approaches, whether that's pharmaceutical approaches or herbal approaches or both. I like personally the Insets model. Most of you who are practitioners have probably heard of this. This was developed by Richard Horowitz. And this stands for multiple systemic infectious disease syndrome. The reason I like this is that, it really highlights the fact that we're dealing with multiple bugs, and maybe even bugs within bugs as well. I also like his the nail in the foot analogy. And for those that aren't aware of that, this is the analogy, if you've got 14 nails in a foot and you take one nail out, you still hurt, right? So, one of those nails may be Borrelia, another one may be Bartonella, but one of them may be heavy metals, right? There's a variety of different nails that can be there, and those we're going to classify as terrain imbalances. And each patient, in my opinion, has a unique pattern of imbalances, and that's one of the challenges with dealing with IMSIDs. So, we're not going to really dive too much into the actual infections themselves because the focus of this is on the terrain. So I'm just introducing here the sort of the age-old bug versus terrain argument, right? With chronic infections, we know that for those of us who are treating chronic infections with antibiotics, that we don't really have the greatest percentage of recovery with antibiotic therapy alone. And I would also include in that low percentage, I wouldn't include patients where we give antibiotic therapy and we get a partial response, but then they plateau, and switching antibiotics, pulsing antibiotics doesn't seem to increase the response. We just stay at that plateau. And then in some cases, you stop the antibiotics and they backslide. And so it almost seems like, that becomes required reading in a way, right? There's also some other concerns with the long-term multiple antibiotic therapy, and we're going to see some of those in the following slides. So Pasteur was our modern germ therapy person. Bacham is the person who's really focused on illness being caused by diseased tissue, and that infections sort of were able to utilize that diseased tissue for their own benefit, right? So we're going to focus on the terrain at this point, the diseased tissue. So biological terrain, what does that mean? A lot of you out there probably are really familiar with this term. For those that aren't, we're really talking about the environment inside the body. And it's a pretty big umbrella term, right? Some of the things that we're going to focus on here are the mycotoxins, which are, a subcategory of the term biotoxin, and they're just, for those that don't know, those are mold-derived internal toxins that people have. Adrenal insufficiency, and I'm purposely not using the term fatigue. I'm going to kind of reserve that for the really severe adrenal issues where we're having people that can't get out of bed. Gut inflammation, mineral and nutrient imbalances. This is something that I'm starting to really focus on. In my practice, I'm always asking the question, what's the cause? When I first started practicing many years ago, really common practice was to do a food intolerance test. You would get people off of their food intolerances, you'd give them some liver support, give them some digestive support, some probiotics, that kind of thing, and many people got significant improvement. But what would happen is if they would backslide on any of that stuff, or they would start to have those foods again, those symptoms would start to return. And that never really felt right. If someone was not able to eat, I don't know, soy, but 15 years ago they were, to me, it felt like we were missing a cause. And so then along came SIBO, right? And SIBO seemed to be an answer to, hey, is there a cause to these food intolerances? Then we can start to ask that question about SIBO too. So, without getting into the energetics, the base answer that I'm getting are tissue mineral concentrations or imbalances. And so I've been really focusing on that more recently in my practice. Metabolic or environmental toxicity, focal infections, and emotional trauma. So I've kind of organize these the way I think about them. And we're going to see that a lot of people, including myself, feel like some of these are more important than others, but I may not address those at the very beginning for reasons we'll talk about in a little bit. Okay, so let's start with mold illness. So we'll talk about a category of toxins that we can experience inside called biotoxins. And biotoxins are, as you'll see up here, chemicals that are produced by bacteria, viruses, parasites, fungus, or mold. Mycotoxins, which we're going to really focus on here in a second, is a subcategory of biotoxins. So they're not healthy for the body. They're often, if they're derived internally by a bug, they're released into the system, into the circulation, when our immune system or some other kind of therapy that we're using kills the bugs, right? And technically that's called a Jerish-Herxheimer. Well, that can cause what's called a Jerish-Herxheimer reaction. These biotoxins can stimulate cytokine production, which is a lot of times a pro-inflammatory chemical that starts a cascade of inflammation, and that really translates into symptoms. There are also anti-inflammatory cytokines, but for the purpose of that, what we're going to talk about today, I mean pro-inflammatory when I say cytokines. They're really difficult for the body to excrete, and so they tend to accumulate, and they also can damage our body's ability to get rid of them as well, which then leads to more of a buildup. The liver will filter out the biotoxins, and it couples those biotoxins to our bile, and our bile is then sent out to the small intestine for excretion. But what we do is we pick up that bile, and you'll see in the picture here sort of an example of the enterohepatic circulation, and we return it back to the liver. So there are patients who don't have an efficient system there, right? So the immune system, what it will do is it'll make antibodies to bind to these biotoxins. And those antibodies' function is to help carry those biotoxins out through the intestines. A little less than 25% of the population genetically can't make antibodies that clear those biotoxins. We're going to talk about who discovered that and that kind of a thing here in a second. So in those patients, those are the patients that continue to recycle biotoxins through their body. They have a real tough time at, excreting them. And every time those biotoxins circulate, they're generating pro-inflammatory cytokines. And so those patients really tend to struggle. So this process is happening. I think it's important to remember when your immune system is killing the bugs, or when antibiotics or antimicrobials are killing the bugs, or both. So the one that we're going to really focus on in this little section is the mold-derived toxins, right? And we'll call those mycotoxins. You're going to see here a list of the most common molds that are causing these. These are molds that we often find in what we'll call water-damaged buildings. More recently, some work has been done to really sort of further define the things that are causing these illnesses. And we know it's not just the mycotoxins themselves, but there's also these other compounds, right? Volatile organic compounds, hemolysins, mannins, that are often existing in these sort of mold colonies too, and that they're also producing illness as well. So it's a little more complicated than just the mycotoxins. So for the practitioners out there, I'm sure this is a really familiar name. There's a doctor actually out of a town called Pocomoke, Maryland, actually close to where I grew up, named Richie Shoemaker. And he identified many years ago an illness that was a biotoxin illness. Well, I'll back up here. For those of you who don't know, he's very close to the Chesapeake Bay in Pocomoke, and there was a hysteria outbreak, and there were a bunch of people who were coming into his office with a bunch of mystery symptoms. And one of the symptoms that was present was a diarrhea / loose stool kind of presentation. And he knew that an old cholesterol binding medication called cholestyramine was often successful when people had sort of intractable diarrhea. So he started giving patients this, and he was surprised that many of their other symptoms started going away quite quickly, and that sort of set him on this path to saying, well, what else is cholestyramine doing? And it turns out cholestyramine is it's a synthetic bile salt, as I understand it, and it's got a really good ability to bind these myco or biotoxins. He's done the majority work. When we're looking at the impact mold has had and water damaged buildings have had with chronic illness, he's termed the inflammatory response that people are having to these biotoxins chronic inflammatory response syndrome. So you'll see that acronym places, CIRS, and that's what that's referring to. And he developed a specific protocol for treating the condition. So just a little bit of data on water damaged buildings. The estimates are 1 in 2 buildings in the US are water damaged. And probably that's going to be less in arid regions like Arizona, but it's probably going to be more in the Pacific Northwest. I would imagine more in the northeastern United States. So this was some data that I was able to find from the insurance research industry. 98% of basements will experience water damage in their lifetime. 14,000 people experience a water damage emergency each day, and 37% of homeowners claim losses from water damage. And this is only what's being reported. So anytime there is water damage, you run this risk of mold developing, even if you don't see it. So oftentimes, early in his work, when Dr. Shoemaker was working with people, he will often run a cytokine panel. So he'll take a look at a bunch of pro-inflammatory cytokine levels, and he would often say to a person, there's mold somewhere, and they would say, well, I've got a brand new house, that's impossible, and they would start digging and they would find it somewhere. So it's a significant issue. How do you get it in? You can get it in through an inhalation. Also, another source of this are vehicles. So that's something that people don't think about. Schools, places of work, that kind of thing. Obviously, you can ingest it, but there's also some exposure from mold or fungus that can grow into in the gastrointestinal tract. And sometimes people will experience extreme Herxheimer reactions to sort of antifungal medications like nystatin, right? Nystatin is an antifungal medication that is really poorly absorbed, so it stays in the digestive tract. And when someone takes that medication and has an extreme reaction to that, that's when we start thinking about more of an internal exposure. Okay, symptoms of mold illness. Now, with all these things, and we're going to see this with things like mast cell activation syndrome as well a little bit later, I want you to think about the symptoms that you know of for these chronic infections in relation to this, and we'll see how it can get quite confusing if we're just having a talk with someone to discern who's dealing with mold versus who's dealing with Lyme versus both. So fatigue, cognitive issues, tremor sensations. This Ike's pick or lightning bolt pain seems to be sort of unique to the mold illness. Anytime someone is given an atypical diagnosis, and I'll often see that in my practice, people will come in with atypical MS or atypical Parkinson's or something like that. That's when we start looking for this. Unusual areas of numbness or tingling. And what I mean by unusual is sort of going back to that slide where we were talking about weird pain patterns. Tingling that doesn't make sense from a neurologic perspective, like it shouldn't be happening. Or the imaging that's been done, right? Tics, spasms, seizure-like events, dizziness, and equilibrium issues. Night sweats, muscle and joint pain, frequent urination, excessive thirst. This is something that he sort of really identified as this excessive static electricity, shocks, and that has to do with concentrations of electrolytes in the blood, diarrhea, loose stool, and many others, right? And so I just say here sound familiar because this can really, it can look just like Lyme disease, right? Okay, so evaluating for a biotoxin, specifically mycotoxin, right? The history can be really important. Exposure to the water damaged buildings or vehicles, some labs. This is more for the folks who are patients here. The HLA-D are 2 genetic markers. This is where he's identified the 24% of patients who can't seem to clear mold toxin or biotoxin in general. And there's some subcategorization of that. Are you Lyme sensitive? Are you mold sensitive? Or are you both? Hormones and inflammatory cytokines, urine mycotoxin tests are available now. Something called a Marcon sinus swab. Now, we're going to talk about that in a little bit more detail later. This is a chronic sort of focal infection that we often see with a mold issue as well. And then identifying where, if it looks like there's a problem, identifying where that exposure is coming in. Is it the home? Is it where you're spending most of your time at work? Is it your vehicle? That kind of thing. Here in Alberta, we get a lot of snow. And so people forget they're getting in and out of their trucks and their cars in the wintertime with snowy boots on. It's melting in the in the heat, and then it's freezing again. Right? So sometimes we forget about the vehicles. And there's something called an ERMI test that you can have run. And over on the right is our sort of an example of our ERMI tests. So with each of these, I'm going to stay away from real specific protocols with this. Everybody has a unique approach to this, or there are a lot. I'll just say there's a lot of different types of ways of approaching this, and for legal reasons, I'm going to also stay away from suggesting certain therapies. But I'll speak to some of these in some detail. And what I really want to get across here with this mycotoxin protocol is, if you are a patient who highly suspects that there's a mold issue or have tested positive, you really do want to have someone who's pretty familiar with the protocol, because you really can't skip steps here. It doesn't seem to work if you do that, right? So number one thing, once you realize that there's an issue, is you got to figure out where that issue is coming from, and you got to avoid it. And I think the stats I've heard from some of these practitioners who are doing exclusively or working with exclusively mold patients is it takes approximately 3 months from the time someone finds out that they've got a mold issue to them being able to actually get out of the house, right? It's a pretty big change, right? But that avoidance needs to happen. After that, appropriate binders to get rid of the mycotoxins, that would be in a lot of cases cholestyramine. Many people cannot, and this is kind of in my experience where people are sort of going out of order here. They cannot use the binders and still stay in that moldy environment. The third one is addressing MARCONs. We'll talk about that, like I said, a little bit later. Addressing the pro-inflammatory cytokines, and then correcting some of the progenitor hormones. So we'll take a look at some of that when we talk about MARCONs in just a bit. Okay, the next topic that I think of. So I don't see a majority of I'm just going to back up. I don't see a majority of patients that are also struggling with mold. However, it's such a big obstacle, and in many cases, it seems to be that you need to address that first before you can have success addressing the chronic infections. That's one of my first rule outs. So in my practice in particular, and probably if you're in Arizona or some other arid climate, it may not be as big a factor, but that's why I've put it first, because it is a big deal. And if you're not crossing that off your lists, you may wish you had a couple years down the road. Okay, next up, adrenal insufficiency. Your adrenal glands they sit on top of your kidneys, like you can see in this picture. And they produce actually a variety of hormones. We're going to talk about cortisol in particular, just because it seems to be the best long-term marker of adrenal stress or insufficiency. But some of the functions of the other hormones that the adrenals produce are that they manage your immune function and inflammation, they regulate blood sugar and pressure, electrolyte mineral retention and excretion, they help with some detoxification, and they help you utilize other hormones like thyroid hormone. So the adrenal glands, from the perspective I'm going to take here, is that they help us manage forms of stress. And so I don't know of any, I would say, patient who wasn't bit within the last 6 weeks in which adrenal insufficiency is not going to be a factor, right? Most of the patients that I see, well, it used to be now patients are finding me because they know they have a chronic infection, but it used to be that I was telling them they had a chronic infection after diagnosis of, chronic fatigue syndrome or fibromyalgia, and they'd often struggle for several years. So, so those patients are going to be in some form of adrenal insufficiency. What you'll see over in the picture for those that aren't practitioners is the normal cortisol curve throughout the day. Cortisol, again, is it's kind of our best marker of longer-term stress. And you'll see it should be high in the morning and then gradually decline at night. So the way I speak to patients about it, and this is obviously simplistic, but it kind of gets the point across, is that cortisol is something that should boost our energy, and it's anti-inflammatory. And it can be anti-inflammatory from a physical biochemical perspective, and also anti-inflammatory as a mental emotional stress buffer as well, right? So I also point out that most of us aren't eating overnight, and so even the stress of blood sugar dropping is enough to send our cortisol up, and that's what we see in the morning. So these stressors that we're talking about, when sometimes patients get frustrated when they go to see their conventional GP and they're told that they're just stressed. And I think they're right, but I think they're right in a different way than maybe they think they are. So with a lot of my patients, their current state of mental emotional stress has not really changed. It's the physical stressors that they're dealing with, right? It's the blood sugar ups and downs. It's the inflammation from foods they're reacting to. It's lack of sleep. It's in some cases too much exercise. I've got a couple of CrossFitters who just can't shut it down, right? And so that's become their stressor. So what I try and get across to patients that it's more than just mental emotional stress, and in a lot of cases it is the physical stuff, right? So that would, if that cortisol curve is accurate, what we should see is a little bit more energy in the morning, less pain and stiffness in the morning, and then starting to quiet down at night. So when we get a stress response, the initial sort of response to stress, we get an elevated cortisol output. And what we're seeing over here is an example of, on a 4-point cortisol, this would be a salivary cortisol test. We can see that the purple line, the patient's values, are outside of the green sort of normal values, right? So we get an elevated cortisol response. Now, I really don't see a lot of patients in this state personally. And in general, they've got more energy, they've got less, physical inflammation or less pain. They may be having trouble with some weight gain. Cortisol seems to prime the fat cells around the abdomen to hold on to weight. So there may be some things going on there that doesn't usually drive them in to see me. But then at nighttime, when you see that elevated level at 10 p.m., a lot of times they'll start to have difficulty with sleep, right? Where they don't have the energy where they could go outside and run a mile necessarily, but they cannot shut their brain down, right? And a lot of people are aware that they're stressed, right? I can remember in my 20s kind of feeling high on stress, and I liked it. I got a lot done, right? But this would be the sort of biochemical pattern we'd see with that. Now, over time, the body, whether the stresses stay the same or you get different stresses that are added onto it, the body doesn't seem to be able to handle that output, right? And so we'll have a drop off. And this is an example of a patient whose cortisol has fallen. And this is where we would say there's some adrenal insufficiency happening, right? So in the morning, they're not able to get into the normal range. Now, in my patients who are coming in with musculoskeletal pain for injections, I'm always screening for this, right? So I want to know, are they more stiff in the morning? Are they more tired in the morning? The pattern sometimes is they start to feel better around 10 a.m., 11 a.m., right? Now, the reason I'm worried about that with my injection patients is that, we've designed the dextrose concentration of prolotherapy, for instance, for someone who has a normal cortisol output. So what I don't want to do is light a fire they can't quench, right? So that's why I'm looking at it there. But in a patient with a chronic infection or with chronic infections, we'll see, this is the most common pattern I'll see, right? And sometimes in the extreme case, we could call this adrenal fatigue. And the adrenal fatigue is really, from a conventional perspective, is really, it's more of an extreme case of adrenal insufficiency. Okay, now there's one other pattern that I'll typically see with this too. Sometimes we'll have a low morning, noon, and evening cortisol, but it'll start to rise at night. So sometimes that'll also happen too, where we've got what we sometimes will call a cortisol inversion. And again, there's some sleeping issues with that. So, the last few curves we've taken a look at, those are daily outputs, right? Those are daily curves. And they can be thought of as snapshots in time. Now we're going to take a look at a curve that's the total cortisol output over an extended period of time. And you're going to see that in the dotted line cortisol there. So let's say I get someone whose output of cortisol looks okay, right? So let me back up a little bit. So when we take a look over here on the left-hand axis and we see normal, I want you to run your finger across, or run your cursor across to this value. So basically both of those values are the same, right? They're the same cortisol output, right, in a day. So what's the difference there, right? Well, the difference is in the stage of adrenal insufficiency that we're in, or that we're approaching. So one of the ways that we utilize to distinguish between this phase and this phase is our DHEA output, right? This is another hormone, it's a precursor to testosterone. So when I start to see DHEA fall, I know we're over here as opposed to here. So sometimes the daily curve is not, we have to look at it a little bit more detail. Okay, so let's keep on going here. So like I said, most people with chronic infections are experiencing some form of adrenal fatigue. The adrenal fatigue can be created by the infections, or the infections that were already present become more active as a person moves into adrenal insufficiency. So, I've seen patients who will describe fibromyalgia as coming on after a car accident. So it's quite possible that those patients had infections, but the stress of the car accident drove that adrenal glands down into the dirt, and now they become symptomatic. So I'll often see a couple that will come in. So patients will come in, maybe one of the couples is neurodegenerating and the other couple isn't, but if we test both, sometimes we get positives for the infections for both people. And so that's interesting, right? It's kind of what's the difference between the two bodies, right? And often that asymptomatic partner has a strong adrenal function. Other things that can definitely drive adrenal insufficiency, sugar, caffeine, food intolerance, mental, emotional stress, obviously alcohol, all those things, lack of sleep, too much exercise, all of that we discussed. Okay, so some of the symptoms of adrenal insufficiency. And again, I want you to look at these symptoms lists in comparison to the symptom list that we have with things like Bartonella and Babesia and Borrelia, right? And there's a lot of crossover. So again, it's quite a trick to try and tease out what are the major factors, in each individual. Okay, so the adrenal thyroid connection. So thyroid hormones, the ones that we take a look at mostly are the TSH, the thyroid stimulating hormone, free T4, free T3, and reverse T3. So free T4 is an inactive form of thyroid hormone. Free T3 is an active form of thyroid hormone. So the majority of thyroid hormone that's produced by the thyroid gland is T4, right? Now, there is a total T4 value, and that's bound T4 to a character or to a carrier. But what we're thinking about here is free T4 as an example. What's available to get into the cell? So what we got here is a picture of sort of the feedback that happens with the thyroid. So the pituitary will release TSH, thyroid stimulating hormone. It'll tell the thyroid to produce T4. And some T3 actually, but in this case, we're just looking at T4 coming out. Then the body will convert T4 to T3, and that'll happen mostly in the liver, some of them skeletal muscle as well. And then those will feedback to both the hypothalamus and the pituitary to shut them down. So, traditionally what we've really looked at is the TSH, and we're not doing so much of that, or hopefully we're not doing so much of that anymore. So as TSH rises, what we're saying is there's probably not enough T4 and T3 to shut it down, right? So it's an indirect marker. Newer tests are the free T4 and free T3 and the reverse T3. So when you're having thyroid evaluation, you really need to make sure that you're having at least the free T4 and free T3 looked at, if not the reverse T3 as well. So with low thyroid function, we could have low hormone output, so that would be the T4 and the T3, or we could also have excess conversion to reverse T3. Now, reverse T3 is sort of inactive hormone, so it's not able to give you a thyroid response, right? Low adrenal output, the connection here is that it increases the reverse T3 conversion. There's decreased thyroid hormone uptake and utilization in the cell. So we get a sort of, this is where you may or may not have heard of this adrenal thyroid connection, where when we're looking at the thyroid, if you get some thyroid values that are off, you really need to make sure that you're addressing adrenal function, and vice versa as well. But most of the time, patients, when they're going into their GP, are being made aware of a thyroid issue. The reason this slide is in there is I just want you to always think, you've got to check those adrenals as well. Let's focus on some testing. So what should you be looking for in terms of testing, or what is it possible to get to evaluate the adrenals and the thyroid as well, right? So there are some indirect markers that I'll take a look at, right? Some direct ones would be serum cortisol. Now, if you're going to do serum, you definitely want to do AM serum cortisol, and that's because that's when it should be its highest. Ideally, you do PM as well, right, so that you can see what's happening there. You want to take a look at DHEA, and specifically in the blood. It's called DHEA sulfate, is the most stable. If you have access to a pregnenolone, that would be great to take a look at. Sometimes there is a decreased sodium to potassium ratio. Sometimes sodium will look okay, but potassium will get above 4.7. That's kind of a indirect marker I look at. Sometimes your triglycerides are high. Sometimes total cortisol is high, or certain cholesterol is high. Obviously, you can do a salivary 4-point cortisol test too. Oftentimes, the DHEA is included in that, and that helps us delineate sort of that where you are. Are you right at the beginning there? If your DHEA is strong, or are you starting to move into adrenal fatigue? In terms of thyroid function, obviously TSH, free T4, free T3, and if you can, get your doctor to run the reverse T3. I think that's important. I would also look at the thyroid autoantibodies as well. Okay, so treating adrenal insufficiency. I'm just going to, again, just make some broad statements about this. Oftentimes people will use glandulars, sometimes they'll even use Cortef, sometimes they'll use adrenal herbs. But I really, when we're dealing with something like chronic infections, I've not seen someone supplement their way out of adrenal insufficiency. I see it as a crutch, and it can be very helpful at the beginning, but it's usually not, you're usually not able to get out of that, right, completely. Some nutritional considerations that you need to add in. I would consider a whole food vitamin C. I'm starting to really take a look at this form of vitamin C versus ascorbic acid, at least in this case. I've just put a picture of the complex, the vitamin C complex, where you'll see much more than just the ascorbic acid envelope. We're going to talk about it in a little bit, but that tyrosinase enzyme in the middle also has coppers bound to it as well. When I look at the mineral depletions or imbalance, the tissue mineral imbalance, I'm often looking at sodium and potassium, right? A natural source of B vitamins, bone broth, amino acids, liver support, glutathione, right? Sometimes even hormone interventions like I mentioned, the Cortef. Okay, treating adrenal insufficiency. So we need to moderate, it's not moderate, but moderate excess exercise, right? So that exercise needs to be rejuvenating exercise, walking, those kinds of things. We really, sometimes, I know with my CrossFitters, that's that's quite a challenge. Definitely identify and avoid inflammatory foods, right? If there's a mold issue, that's another driver. If there's a metal issue, we're going to talk a little bit about that in a bit. Distinguishing between volume of metals versus, an allergy or inflammation or an intolerance to metals too. Restructuring home and work schedule, working on stress management. If there are issues with past trauma, we're going to see a little bit in the future here in the presentation. There's some issues when people are accumulating copper as well, and also a connection to nature. And I know that some people, when they get, it's not uncommon when they get these chronic infections that they are getting from ticks, they want to close down from that. Okay, gut inflammation, leaky gut. This is probably another sort of situation similar to adrenal fatigue, in which most people have this when they're dealing with those chronic infections. In terms of biological medicine, this is a huge focus. This is one of the distinguishing sort of focuses in biological medicine. I have a colleague who I had a conversation with today who was telling me that the way that she distinguishes between things like functional medicine and biological medicine, not only is our look at the teeth and things like cavitations and other focal infections, but also sort of the terrain, where in functional medicine sometimes we're focused on the biochemistry and oftentimes intracellular biochemistry, right? And but we forget about the sort of in between, from the bloodstream to the cell, right? Which you've got to go through the matrix. So this gut inflammation is a big part of that. So approximately 80% of the immune system resides in the gut. Associated lymphoid tissue, the GALT. I used to hear this percentage touted in Germany all the time, but I had never seen any English research that said that. And several years ago, I was at the ILATS conference in Boston and just saw the number in research. The number was somewhere between 70 and 80%, so it's pretty big. I've just given some examples of where these reside in the intestine, where these immune cells reside. So some evolutionary considerations, sometimes I like to think about things like this, is that, other than a break in the skin, probably the most common route of an infection is going to be down the mouth, right? So it makes sense to load our immune system there. So intestinal hyperpermeability. These are some of the markers that I look for in conventional blood work that may clue me in that there might be something going on here. When white blood cells get, to 5.5. So for instance, I had a patient come in the other day who some PRP, and her white cell count was 3.7, and her GP wasn't really that concerned about it. And I know that her true total white blood cell count is probably not low, because we're just sampling the blood, right? And obviously the white cells can move from system to system, from compartment to compartment. So the question is, where are they, right? And if we were to make a guess without any other information, a low white cell count, I'm always thinking gut or sinuses or both, right? A low urea nitrogen, low iron sometimes with malabsorption, red blood cell indices sort of indicating B12 or iron deficient anemias, any kind of increased inflammatory markers, cholesterol, ferritin. I consider some of the cholesterol markers inflammatory markers, and certainly ferritin, especially if serum iron doesn't look that high or excessively high. I always think of ferritin as an inflammatory marker. Okay, so moving down here, so hyperpermeability. What I've got in this picture is we're seeing sort of what can happen with leaky gut. Now, so we've got these mucosal cells that line the intestine, and they're held together by little chemical bonds called tight junctions. And when there's an inflammatory situation, those tight junctions can start to get loose or leaky. Now, food should be forced through those cells, right? They've got to be taken out by a receptor, they've got to cross over and be kicked out the other side, which sort of implies that they also have to be, pretty fully digested to be able to cross over. But when we get these breaks in these tight junctions, now pieces of food that might be a little bit too big now have access to inside the body, right? And there is a size threshold where they become antigenic for those of us who aren't practitioners. And antigenic just means the immune system starts to recognize that and starts to make a determination, is this me or not me, right? And if it's not me, we get an inflammatory response. So many factors can influence the development of leaky gut. So sometimes, you know, I don't know if anyone has ever taken cortisol cream or used cortisol cream. Oftentimes there's a sticker on there that will say, danger may thin the skin, right? Well, you know, our skin is epithelial tissue, and this is also epithelial tissue. And so we can get a loss of integrity with an increase of cortisol. Now, cortisol is a cortisone analog, right? So we have very similar actions to cortisone with cortisol. So when we get a rise in cortisol, which could be any kind of a stressor, we're going to tend to get a friable digestive tract. So again, the ability to large size particles to cross over the gut lining, interact with the immune system, and antigenic. This results in immune system activation, inflammation, food intolerances, and even more cortisol release in response to the inflammation. So I've just thrown this in here because there is emerging evidence that glyphosate, you know, everyone has thought this for a while, but there's emerging evidence that glyphosate can be part of what's driving this, especially when it's knocking down the beneficial microflora in the gut. There's some concern about glyphosate in not only by itself, but also in combination with an elevated aluminum level as well. So we're going to see that a little bit later. So a lot of times there are digestive symptoms that are present, but also other non-specific symptoms, which may or may not be digestive, right? Things like oftentimes people will have clogged sinuses. We can even see blood pressure ups and downs, right? Some of the options for testing, we've got some blood testing where we're testing antibodies. For those that aren't practitioners, IG is an abbreviation of immunoglobulin, which is also another term for antibody. So we've got a couple of classes of antibody that we can test, IgG, IgA. There are other antibodies too, but those are the ones that I'll use. There is a type of a test called an ALCAT, which looks at total white cell irritation. So not antibody production, but white cell irritation in response to foods. Some people will just forego that blood testing option, and they'll go for what's called an anti-inflammatory diet. There's many of those published online. And basically, you just take the biggest allergens and eliminate them. And the idea is that you're probably going to hit on a big percentage of your allergies just by doing that. Sort of the gold standard used to be, or still is, as far as I know, an elimination and challenge diet. It's just really tough. It seems like it's very tough today. It was tough, you know, back when we learned about it from Alan Gaby, but you know, it's even tougher today. So some of the evolution that I've commented too is to realize that during that 6-week period of time, we need to work on some underlying causes, right? Things like SIBO and SIFO, which we're going to talk about in a little bit. We've got to do things that are going to help heal the gut lining, right? And if there are things like heavy metals that we're having a problem with, we need to also help with those too. Okay, so intestinal inflammation. Some of the issues with having that, there's immune diversion from other areas. You know, I used to see this with kids that had ear infections, right? Almost always, you would ignore the ear infection and you'd go after whatever's going on in the gut. And there was this idea that there was an immune diversion away from the ears to deal with some kind of inflammatory response in the gut. And 95% of the time, you know, either you treated the ear infection one last time or it just went away on its own but never did return. Malabsorption of nutrients, increased liver strain, water retention, lymphatic congestion, predisposition to autoimmune disease. Sometimes we forget, you know, this is just digesting alone, having, you know, just friction of food moving through the digestive tract and having to replace those cells daily, that's a tremendous ATP drain, right? An energy drain on the body. Depression and anxiety, just so happens that the gut is a site of the majority of serotonin synthesis too. So over to the right is a molecule of serotonin. Sorry, I'm just looking at the chats here. I just want to address these as they come up. What's the best way to check heavy metals? We're gonna look at that in a second. In terms of taking colloidal silver and affecting metal buildup, colloidal silver is something that I don't use. I don't think I'm satisfied with the research on colloidal silver at this point. It wasn't long ago that we gave mercury for another spirochetal infection, and it didn't kill that. It just made us crazy, right? So I'm cautious with that. I think there's other things we can do, and I'm not saying that it is necessarily a negative thing, but I know that on the heavy metal challenges that I do and the heavy metal tests that I do, we don't look at silver, so I don't have a way of seeing if it's accumulating. Okay, so it's about 6:30. I think I'm running. Actually, surprised I'm running a little bit behind. We're going to kind of move through this a little quicker, and you guys just let me know if you need me to stop. Okay. So obstacles to healing the gut, right? These are things that are potential causes for this leaky gut. Small intestinal bacterial overgrowth, SIBO. In the research that's been done, a vast majority of IBS patients are positive for SIBO. And I'll just give those practitioners just a little heads up if you haven't found this on your own already. I just stumbled upon this, is that I have a subset of male patients who come in who deny any symptoms, just their cholesterol has started to rise and their doctor's given them 3 months to get their cholesterol down. Oftentimes I'll see a CRP rise as well, a C-reactive protein rise. I started doing SIBO testing on these patients, and it just continued to come back positive, even though they denied any gastrointestinal symptoms. What I was doing is I was running them through a 4-week herbal protocol for SIBO. I'd retest the cholesterol and the CRP in a month, and many times it dropped, right? So I couldn't rely on their symptoms because they were, reportedly asymptomatic. But just sort of a little tidbit there. Small intestinal fungal overgrowth, SIFO. It can also be present with SIBO. Now, and then parasites. And sort of the common knowledge at this point is that they are probably being underdiagnosed in a pretty big way. Okay, small intestinal bacterial overgrowth. Let's dive into this just a little bit. What happens is you get some damage to these little organelles in our digestive tract called the migrating motor complexes. Now, everybody is aware of sort of the contractions that happen with food, right? That moves food down from our stomach to our colon. Well, these waves of sort of gentle sweep that happens in relation to these MMCs happen between food, and this is something new. This, at least wasn't known at the time that I was in medical school. So we have this, especially the biggest times. If we've got for most of us that means dinner to breakfast, we should be having this gentle sweep that comes in waves that pushes any kind of thing left over down towards the colon. So the small intestine isn't aseptic, it's just that it should have a significantly low level of microbes there. There seems to be 2 primary groups that cause this. There's a hydrogen-producing group of bacteria, and there's a methane-producing group. And sometimes we call them bacteria just for simplicity's sake, but they're a group called archaea. So there are some kind of interesting, I think I'm going to get into it in a second. If I don't, I'll make sure I come back to it in terms of patterns of SIBO breath testing that we'll see. Okay. They live on carbohydrates in the diet. They can consume or sort of steal nutrients from us. They impair some fat, fat-soluble vitamin absorption. And this is where the IBS symptoms come in. We'll start to get gas, abdominal symptoms, that kind of thing. And the inflammation that they cause, again, causes that leaky gut, which drives the food intolerance. Sometimes we'll see things like chronic pain. It's really interesting to see the associated conditions. They can read like rosacea, chronic fatigue syndrome, fibromyalgia, rheumatoid arthritis, restless leg syndrome. It's quite interesting. Okay. Oh, and so here they are, some of those associated conditions, right? GERD, some of the things that we're seeing a lot, or you may have experienced yourself, right? Sometimes things like the proton pump inhibitors that we're taking, those acid blockers we're taking for heartburn, will potentiate a SIBO overgrowth. Some of the nonsteroidal anti-inflammatory drugs will also do the same thing. So just be on the lookout for that. Now, just an example of a SIBO breath test. So what you do is you'll get a test that hopefully contains lactulose. Now, there's a little bit of debate about what's the best provocating agent for these organisms. So glucose is probably the best. The problem with glucose is it's absorbed quickly. It doesn't make it through the small intestine all the way. Lactulose is not supposed to be absorbed, so it does make it through the entire small intestine, although it's not quite as good as glucose, probably, right? So usually what you'll do is you'll fast overnight. In the morning, you'll drink a glass of either glucose or lactulose, and then every 20 minutes, you take a breath sample. And what we're looking for is we're looking for hydrogen or methane, or both. The generally agreed upon number is greater than 20 parts per million increase over the previous value is positive for hydrogen positive. And methane, it's a bit higher, but most of us are looking at a 3 and over 3. Now, so sometimes we'll see both high, right? And then we'll know for sure there's hydrogen and methane. Sometimes hydrogen will be low, but methane will be high. And it's important to remember that the methane producing archaea, their food is hydrogen. And so you may have, or there may be such a high colony count of the archaea that your methane is being completely taken out by the archaea bacteria, and that, or sorry, the archaea organisms, and they're producing, and all you're seeing it coming out is methane. But it does mean you have hydrogen and methane together. You can have hydrogen alone or hydrogen and methane together. You can't have methane together, or you can't have methane alone because it does need the hydrogen producing bacteria. Sometimes I'll take a look. What this does, and the SIBO test doesn't take a look at a SIFO. And so in that, coming back to the 84%, so which line is methane? It's the pink line. Okay? So coming back to that 84% of IBS patients who are positive for SIBO, probably not, the rest of the 16% is not SIFO positive, but I would gather there's probably a big percent that is of that 16, right? We don't test for SIBO on this, or sorry, SIFO on this test. So a lot of times you're going to see organic acids testing referred to several times through this presentation. And what that does for me is that'll give me some breakdown products of fungus and yeast, right? So it's an inference I'm making. SIBO treatment, there are antibiotics that are specific for hydrogen and methane producers. Just some comments for the practitioners who may not be aware of it. We've got a great antibiotic called rifaximin that doesn't get absorbed. Unfortunately, in a lot of cases, it's not covered, at least where I am, because it doesn't get absorbed. It can't be used for other infections, so it's not covered by health insurance where we are. So it ends up costing a little bit more than the herbal treatment. So oftentimes I'll do the herbal treatment instead. But that only takes care of the hydrogen producers. For the methane producers, you've got a couple of choices. Mycin is one, and which does have some potential side effects. So that's one that I'm quite careful with. And metronidazole is another. There are herbal remedies out there. There's a small study showing slightly better outcomes than antibiotics. So I'll use them. I'll use the herbals quite a bit. There's also some elemental diets, and those seem to show quite a bit of promise. Now, some of those elemental diets, or at least the powder mixes were kind of bad tasting. As I understand it, I haven't used this very much, but as I understand it, there's some new things available that are a lot more palatable. Approximately 2/3 of the patients will relapse at some point. So a lot of times multiple treatments are required with this. I don't tend to do dietary changes during the treatment phase because you do want those bacteria happy. We're trying to arrest cell cycle, right? Which means they have to be cycling, especially if we're using the antibiotic prescriptions. So I say the dietary changes for afterwards. Okay, small intestinal fungal overgrowth. Approximately 40% of the patients with chronic abdominal symptoms can be present with SIBO as well, very similar symptoms. I say down here Candida and others. For patients, we often use that term Candida. Lots of people have heard of it, but it's not the only one that can be there. Sometimes this is associated also with antibiotic prescription medication use as well, right? SIFO assessment and treatment, the best assessment is a culture of the small intestinal fluid. That doesn't happen very often. I'll use, again, those organic acids testing, the urine testing. I'll take a look at low white blood cell count and elevated monocytes. So, sometimes when we have an elevated neutrophil count with a decreased lymph count, I feel like, okay, we're dealing with maybe the immune system's paying attention to a bacterial infection. But when I have, normal neutrophils, normal lymphocytes, normal eosinophils, normal basophils, but that monocyte count is high, then maybe that's pointing to something like a fungal issue or a candida issue, yeast issue. Prescriptive antifungals, SIBO herbal treatments, demulcent herbs, population with beneficial gut microbiomes. One of the advantages to the herbal treatment for SIBO is that most of those herbs are also antifungal too. And so even if you don't have an assessment for SIFO, but you've got a positive SIBO, you're usually hitting both. Okay, the parasites. Again, this is the one we think is probably underdiagnosed. It's important to think about intestinal versus other locations. In the intestine, we have complex parasites, worms down to single celled. We have liver flukes people have heard of. We have blood-borne parasites. That's our Babesia. We have, brain-based parasites like Toxoplasma. Then there's this a bit of a controversy over something called ropeworm. Now, it's being treated by one of the Lyme groups quite a bit using an enema-based protocol. But there's a lot of controversy as to whether it's a complex organism or just a biofilm that contains a bunch of different species that might even make up part of the normal or abnormal dysbiotic flora, okay? So people, whether it's really complex organism or not, people seem to get better when they treat that. These steal nutrients, they appear to concentrate heavy metals, so we've got to be careful when we do a parasite cleanse, especially if there's a significant Herxheimer reaction. What we also might be getting, in addition to just liberating a bunch of biotoxin, we may be liberating other bugs that are within those parasites. We also may be liberating heavy metals, right? That's sort of the rationale behind what's called the Gubarev protocol for the ropeworms, which is an enema-based protocol. And the goal is to get rid of the bugs whole, so there's not a break apart, right? There's some liver stress often, immune diversion, allergy desensitization, or sensitization of varying symptoms. So I've just been told that we only got 20 minutes, so I'm going to speed up here a little bit. And you guys, if there's something that I'm going past, you really want to learn about in more detail, just give me a shout. Okay, diagnosing, I often look at eosinophils and basophils and elevated monocytes, right? So eosinophils and basophils can tell us about allergy reactions, but if there's an elevated monocytes, then a lot of times we're dealing with some kind of parasitic issue. It unfortunately doesn't tell us where it is, but it helps us. There is a comprehensive digestive stool analysis, the 3-time ovate parasites, which helps us with a microscopic examination of the stool. There are better labs than others for that. Sometimes there's some urine testing that can be done, heavy metal testing, and then obviously some energetic testing methods when we just have reached the limit of our technology with being able to assess these. Okay, intestinal parasite treatment. In my opinion, we need to take care with some heavy metal binding and some chelation, because if we're going to break apart some parasites, there's a phenomenon that we call retoxing that can happen. There's definitely oral antiparasitic herbs that you can go into an on and off cycle. There's a little bit of thought that maybe your liver might upregulate some breakdown of some of those herbs within a couple of weeks. So we think about cycling them, and we also think about changing them. Also, herbal suppositories, and this is something that I really started working with myself. I have a compounding pharmacist. For those of you who are practitioners who will take, I like this now, I'll just say I don't have any vested interest in any of these, any testing companies or supplement companies. I like the 10-in-1 oil, and I'll have that made into suppositories. The Guvarev protocol, that inhibit-based protocol, that's a tough one. I could see where it would work in Europe. But it's a hard one for me to, it's like you start with a milk and salt enema every 4 days that you got to end up holding for a couple of hours. That's a tough sell in Cowtown, Alberta. So I don't get a chance to use it quite a bit, but those who do use it do feel like they get some benefit. Simon Yu, who is an MD down in the States who focuses on this, he's developed by himself, and you can also find it under Clean Heart's name. He's just developed a cycle of anti-parasitic prescription medications as well that I've used. Okay, so this next topic, this mineral nutrient imbalances, this is where I've really, I'm kind of seeing this as my foundational sort of treatment at this point in terms of terrain. I think there's a lot here. It's a gentler treatment. It takes some time to see results, and that can be frustrating, but I think it's quite foundational. Now, what I'm going to start with is this idea of KPU and HPU. So just because it introduces us to this. So this was something that had been discovered looking at schizophrenic patients. It used to be called MAV factor, and there were a couple of other names. It's a byproduct of heme synthesis, one of the products, or one of the building blocks of hemoglobin. According to Clean Heart, 80% of his patients have it who have Lyme disease, 80% of patients with autism have it, 75% with elevated metals. A lot of times it's thought to be genetic or infection induced. This MAV factor, this HPU, what it'll do is it'll bind minerals and some nutrients in the urine and excrete it, right? And so we get really low in these minerals, like zinc, for instance, right? It's a pretty big cofactor for the immune activity, right? So, so what I'm going to do is I'm going to hit on some of these just to kind of save a little bit of time. I've got some zinc deficiency syndrome or symptoms put up here. You'll be able to look back at the recording and take a look at this. And B6 deficiency symptoms, manganese. These are all again in this KPU-HPU syndrome that we see. Biotin deficiency, even arachidonic acid deficiency. So again, you're going to start to see some crossover. Now, there are a lot of trace minerals that are assessed when we take a look at this, and I'm going to really focus on just a few that I think practitioners may not be aware of, and certainly a lot of patients aren't aware of. So my question regarding KPU and HPU, again, is what's the cause? Is it really just genetic? And so looking deeper into other minerals that have an impact on KPU, copper. So copper is one of those minerals that we need for adequate energy production. However, in excess, it can become toxic. Now, one of the issues is that we're taking a look at blood markers of these minerals. And blood is kind of like it's a transport medium, really. So for some things, it's great to take a look at, but for others, we're only taking a look at what's being transferred from one compartment to another. And that's the case with a lot of minerals. So when copper is too high, the body will store it in the liver and the brain, and we really don't get a chance to see it go, chronically high in the bloodstream. It's associated with inflammation, pain, menstrual problems, hair loss, even things like adrenal and thyroid disorders. So copper to me is something that is difficult to assess. You can assess it with a liver biopsy. It's just nobody does that. Same thing with iron. Iron tends to store an excess in the liver, and that can be assessed that way, but we just don't do it. Copper is something that on a series of hair trace mineral analysis, we'll see come out eventually if it's in excess. And when we are able to identify it and start to dump it, people's bodies change. Their response to the infections change. Their ability to heal changes. Their ability to sleep. In this previous slide, we see how it might impact our melatonin production, right? So, and then in this slide, we're seeing down here the adrenal production. So, why might copper be an issue? We've got it in the environment in the form of copper pipes, but estrogen makes us pull copper from the environment. You know, a higher estrogen state will make us pull more copper from the environment than a lower estrogen state. And so obviously females that are cycling are going to tend to pull more copper from the environment. Anyone who has taken an estrogen-based birth control pill will tend to do that. Copper IUDs obviously can do that. And we have even food sources like copper sulfate that's often sprayed on some fruits and vegetables. There are some effects on other minerals like magnesium, zinc, potassium, B6 levels, all dropping. Calcium can increase in response to the copper, so we kind of start to get a chaotic mineral pattern. It can have significant impacts on the brain, impacting neurotransmitter production. You can see impacts on the neocortex, the amygdala, the hippocampus, the diencephalon. You know, one of the people who really started paying attention to this was a guy named Rick Malter, who is a psychologist, and he started using mineral balancing in his practice and saw some incredible results with that. Now, this is going to be hard to see, you guys, on this, and I apologize again because we're not on that big screen, but this came in yesterday, and I added this to the presentation today. So this is a second page of a urine provocation for heavy metals. This is where the practitioner ran minerals. So this was a new patient that I saw, and this was her third heavy metal test. Now, each metal test where they looked at minerals, her copper was normal each time, except for this one. You can see that this blue line here is the copper that went right to the right. Now, we call a mineral test in a series when someone's copper rises as showing their copper. And so in this patient, she's really, really struggling with chronic infections. And up until this point, she's been focusing on the infection itself. Here, we've got a copper situation that must be addressed for her to be able to overcome that. So this is just an example of that. Iron, very similar to copper. When it gets too high, it'll start to store in the liver and into the brain. It's necessary. This is just showing us a little bit of a how iron is transported and moved between different compartments. There's a chemical here called ceruloplasmin. We're running a little bit too behind to really get involved in the ceruloplasmin, but there's a copper connection there too. In men especially, it's very rare for me to see a 30-year-old man with a ferritin, which is commonly thought of as a storage form of iron, under 200. Now, a new look at the research, it's a great book that came out 2 years ago called Dumping Iron. And there was this new look at the research where he started to look at, were there connections between the diseases of aging and ferritin levels? And he saw that somewhere between the 50 and 70 mark is probably ideal. Anything over 70, we have significant increases in the inflammatory diseases of aging. And so again, I'm seeing people very regularly over 200, especially males. So now we all often have to look at, serum levels of iron too. If the serum level of iron is low and the ferritin's elevated, then that's really, I'm interpreting that as being more inflammatory in nature as opposed to holding iron, although too much iron is also inflammatory too. Okay, I'm gonna keep on going here. So what I took you through, and you can re-look at this presentation here, and we're going to take a look at some of the issues with iron. There can be deficiency. Most people know about that. I will say, I want to point out one thing, that in people who are constantly taking iron orally and they're not improving with their deficiency, you need to look at copper, because there can actually be a deficiency of copper that can prevent your body from transporting iron from the intestinal cells into the blood. Elevated ferritin, again, we talked a little bit about that. The normal range here in Alberta is 12 to 300. Again, it's looking like 60 to 70, 50 to 70, somewhere in there is our ideal ferritin level. I'll also suggest here, I just want to make a point to point out this very last line. There are some that are starting to look at levels greater than 30, and this is, again, with a normal serum iron level as being possibly a sign of subclinical scurvy as well, which is, for everybody probably remembers, it's a vitamin C deficiency. And we're talking about not an ascorbic acid deficiency, a vitamin C complex deficiency. Just some symptoms of iron overload. We'll go past this: elevated ferritin. I'm wondering if this copper and ferritin issue might really be connected to what we're seeing here in terms of, I think the last count I heard was 30% of those doing abdominal ultrasounds are coming back with non-alcoholic fatty liver disease, right? So I'm wondering about the part that that's playing. We're just not maybe connecting it. Magnesium, I think that this is really interesting in terms of stress. Some people will talk about the level of a stress someone has as their magnesium burn rate. There's about 9,000 total plus total body enzymes. We know at last count about 3,700 involved magnesium, right? Some of the issues with regards to low magnesium: alcohol intake, excessive stress, excess exercise, low dietary status, kind of thing. Iodine, just want to touch on that too. Iodine is found in, everybody probably has heard about the iodine thyroid connection, but there's an iodine breast connection, there's prostate connection, potentially female reproductive organs, that kind of thing. In terms of iodine, I'm really interested, not necessarily in jumpstarting someone's thyroid, but I'm interested in a halide detox. So iodine is antagonistic and competes with fluorides, bromides, and chlorine compounds. And you'll see those in the halide column here in the green. So I'm interested again in that, in the detox component here. Now, from the mineral assessment, if someone is asked about the mineral assessment, there are some blood values you could do. There's things like red blood cell magnesium that you could take a look at. But I think the best tissue mineral analysis is a hair test. Now, there's a difference between hair tests. There's some great variability in hair test results, and it seems to be in labs that wash their samples. There are two labs that I know of in the US that do not. They're TEI and ARL. They're down here. And they seem to be more consistent from sample to sample. Now, I want to say also, you're sending in an inch to an inch and a half of hair, which is approximately 3 months of growth, right? So you're getting a picture of 3 months. You're not getting the total value, and really to get a good sense of the total value, you need a series of these that are spread out 4 to 6 months apart. So that would be sort of reflective. If you think back to the copper, right? A lot of times people aren't showing a copper load on an initial test, but when you start putting things in that are starting to cause that body to dump copper, copper will start to rise, and they'll quote unquote show their copper, right? There's some other tests here to sort of evaluate the urine KPU, HPU test, urine iodine loading test. You want to do that with the halides if you're really interested in the detox component, and that's really what I'm interested in as well. Okay, toxicity, metabolic and environmental toxicity, lots of different kinds. There's hormones, there's regular products of cellular metabolism, halides, which we talked about, which I think are a big deal, especially the bromides. Those are potential carcinogens. Heavy metals, we're going to speak a little bit about that, and the non-metallics, right? So I'm going to skip over this. I'm going to allow you guys to just kind of catch back up on some of the anatomy and some of the things that of where this toxis or where this detox is happening. And I want to go to heavy metals. Someone asked a question on that. So I think it's important to realize there's a difference between volume and reactivity. So you can do a volume test, which is usually done, right? And that's where you look at the level of metals coming out of the urine, usually in a provocation test. But there are people, and I'm one of them, that actually have a reaction to metals. So they have an inflammatory response to metals, and mine was to lead. And so you could think of it as a food allergy almost, right? Like if you've got a food allergy to wheat, you got to get the wheat out type of thing. So there are problems with having volume because of, banging up the enzyme, the workings of your enzyme systems. But if there's also an inflammatory component, that can even be worse, right? If there's an autoimmune sort of condition, I always look at the inflammation as an issue. And that test that can be run is typically called a MELISA, M-E-L-I-S-A. That's the reactivity test. Okay. heavy metal accumulation and testing, there's blood testing, but I want you to realize that that only shows you the last 3 weeks of exposure, so it doesn't show stored metals. So the example is gadolinium. You know, we assume from a conventional perspective, after you have an MRI with contrast dye and you don't show gadolinium in your blood test, that you've cleared it all. But you do a provoked test where you're pulling it out of your tissue, and the gadolinium, you know, pins the chart to the right. So pre and post provoked urine testing. There was some conventional objections to the post-provoke, so that means we give you a chelator and then collect urine to see what comes out. And the objections were that we were using non-chelated normal ranges, as I understand it. So what we did is we used a pre and a post test. So we do a pre-test, which means no chelator, just what comes out in your urine, and then we provoke it with a chelator, and then look at what comes out, and usually there's a massive difference, right? Hair tissue mineral analysis will also tell you mineral, but oftentimes initially I will see that low, and then it'll end up going high, kind of like showing copper. So serial testing is needed, and then again, we've got this energetic testing that's a possibility. Some treatments, I just want to sort of speak to some of these. You know, there's IV chelation, oral chelation. I want to speak to the melatonin here that I've got under. Klingard in this group is really looking at melatonin now as a brain drainer. And in people that have done melatonin and feel really foggy in the morning, they added DMSA to the dosing at night, and that sort of sluggish feeling went away. So they're feeling that what they're doing is that they're draining heavy metals from the brain utilizing melatonin. There's transdermals, there's rectal suppositories. There's even foot baths. Now, apparently, there's a group that's done a urine test for metal excretion, had a foot bath done, and then test on serial days 1, 2, 3 from the foot bath, and they've seen that the urine on day 3 is pumping out 600% of aluminum from the baseline. So I know there's a lot of controversy about foot baths. I think it's pretty clear to everybody that if they work, they don't pull things out through your feet like we were being told, and that the color change in the water doesn't have anything to do with that. What I think is going on is I think that if it is working, it's a acupuncture, like an electrical acupuncture stimulation to the meridians in your toes that are in charge of detox. Saunas can be done as well. Some non-metallic assessments, there's iodine loading tests, we talked about that, the organic acids testing, urine testing for non-metallic toxins. I use Great Plains Lab. There's one called GPL Tox. They have another one called GPL Glyphosate that looks at glyphosate, and obviously you can look at the energetic testing too. Focal infections. These are things that we really look at in biological medicine. So we're talking about infections in different places of the body that can distract the immune system. The big one that everybody thinks about is in the teeth. And so what I've shown here is I've shown just a meridian chart. So their different teeth are connected to different acupuncture meridians. And I think it's interesting that in Europe, what they'll do to impact the liver, let's say, is, or let's say the gallbladder, they'll inject some herbs for your gallbladder into a gallbladder point, right? And they feel like they're getting as much action, but with much less of a dose by injecting into that meridian. So that would be an example of using a medication, for some benefit, right? In these focal infections where we're having infections in the teeth, the potential is that infection is adding biotoxin or metabolic waste to that meridian on a daily basis, right? So doing the opposite, making it sicker. This is just an example of a cavitation in the tooth where there's dead bone. I have had patients who have had tremendous results just sitting in the chair by having these drilled out. One in particular I'm thinking of went to I think it was Austria, and had an amazing improvement just within hours. Marcons, I said we would get back to that. Marcons is an infection in the sinuses. It impacts some progenitor hormones in the brain. It's an antibiotic resistant staph. And so there's some nasal sprays. There's kind of a tricky way of treating that. What I showed here is the nasal swab for it. Those swabs your doctors can get, and for those who are practitioners, you can get. But as I learned, that the comment was, if when you go in for that swab, if you don't get a little bit of brain, you didn't go deep enough. So we need to. I just showed that because we can see how deep that swab's getting. Okay. This is a look at the biotoxin pathway that Dr. Shoemaker sort of elucidated. Up here is where the biotoxins or the mycotoxins come in. What they end up doing is they end up down here and dropping off this progenitor hormone called melanocyte stimulating hormone. This is a hormone in the brain, and this is something, again, that I had never heard of. Most conventional docs will not have heard of either. So we can see here a lot of different impacts with that reduced MSH. This again ties into the Marcons, and in many cases that ties into mold. Okay, so some focal assessments: biologic dentist, Marcon's nasal swab, some yeast and fungal nasal swabs. Again, an organic acid test can tell us, tonsillar swabs, cervical swabs, energetic testing. Now, I wanted to talk just briefly about emotional trauma and thought patterns. So I wanted to let you know about a great article that just got published. It was in the July article of the Townsend Letter called "Casting a Broad Net to Maximize Lyme Disease." Now, the person who wrote this, Scott Forsgren, who some of you may have known as the Better Health Guy, has got a great blog cast online, interviews a lot of people in this field. He's been through Lyme and mold illness, and this was a quote: "Today, my belief is that exploring mental and emotional health is a top priority, followed by detoxification and lastly, supporting the body against microbial overgrowth." So this is something that we hear a lot from practitioners. However, and I hear it a lot of times from patients who have gotten past this NSAIDs issue, but it's something that people often can't hear at the time. That's why I've put it last. I think it's very important. For those of you who are patients and those of you who are practitioners, maybe new to this, I think it's very important, but it's something that patients are not in general open to at first. I had a personal experience with this. I was diagnosed at 18 with ulcerative colitis, and since asymptomatic and I don't take any medication, I've got clear colonoscopies, which isn't supposed to happen, but this was certainly my experience when I was first diagnosed. I had people telling me it was in my head, and I certainly couldn't hear that. But there also may be this impact on terrain issues, right? So things like the heavy metals, the copper, the iron, that may prevent someone from being able to go there mental or emotionally. Some of the explanations for this come from the epigenetic research and the mental emotional connection to the autonomic nervous system. Epigenetics, pretty interesting. We've got these traits that are heritable that don't seem to be passed by our DNA. One kind of quick sort of research paper that was published talked about transmitting fear in mice. So mice were classically conditioned to a smell and a shock on the floor. And when that floor was shocked, they got stressed, obviously. And then pretty soon, all they had to do was smell the smell, and their stress hormones would go up. So they took the sperm from those mice and they inseminated female mice that had not come in contact with those male mice. And the offspring already had the fear response classically conditioned into them, right? So that's pretty interesting. This is sort of the connection to some of the transgenerational mental emotional issues you're going to hear about if you haven't already. The autonomic nervous system, we can think about it as our unconscious nervous system. Basically, it acts like a dimmer switch. Most organs and glands have both sides, are fight or flight and arrest and digest, and they kind of fight, for control of that organ, right? So obviously, it's coming from the nervous system, and our brain has an impact on it. So how the way we think about things and our emotions, directly translates into that. There's a complex interplay here between not just neurotransmitters and thought patterns, but also hormones too. And this forms the basis of some of the neurofeedback therapy that we've seen develop. Some of the really good therapies I've encountered are something called emotional freedom technique, EFT. A lot of people have heard about that. EMDR, which can be very, very helpful. There are some really advanced neurofeedback programs out there right now. Clear Mind Center is one that I'm familiar with. And even you might hear about family constellation therapy. Now, again, I've just got a note down here. There may be a reason that people are not able to hear this or move forward with this early on in treatment. And there may be other things, heavy metals, minerals, low MSH, those kinds of things that we talked about. Just wanted to make comments about mast cell activation syndrome. This is getting a lot of press in the Lyme community at this point. Mast cells are inflammatory cells that seem to get activated in any kind of stress response. People tend to experience allergies, and they become really profound, and they start to become allergic to lots of things, but lots of environmental sensitivities. I'm always asking the question, what's the cause? I don't know if I don't see this as much because I'm doing that sort of sodium, potassium, other mineral work that's making people less susceptible. In any event, it's a clinical diagnosis. There is one genetic polymorphism that can predispose you to it. You can have a bone marrow biopsy that will help diagnose it. I've put some symptoms up here. Again, look at this list as if you're looking at symptoms of Lyme, Bartonella, or Babesia. They're very, very similar. Also wanted to touch on, there's a group that's working with ammonia and the fact that Borrelia produces ammonia, and also the fact that Borrelia biotoxins and die-off is stressing our liver, which hurts our, not only we have this increased ammonia production, but our ability to process it starts to decline. And ammonia can act as a neurotoxin. So that's something that it's been looked at. There's also an electromagnetic frequency sort of potential issue. Lots and lots of controversy about this. Studies are conflicting. I'll tell you how I think about it. I think about what's called the Schumann waves. And the Schumann wave is an electromagnetic frequency that's set up between the Earth and the ionosphere. And I think about it in terms of sleep. So our delta waves, which is our deep sleep, restorative sleep, goes from 0.5 to 3 hertz. Our theta waves 3 to 8, our alpha 8 to 12, beta 12 to 38. Now, if you live in a place like my house, you have an electric outlet about 1.5 feet from your head, on your behind your headboard. That's pulsing at 60 hertz, right? And your brain can become trained to those frequencies. So it's very hard for it to get back down into those restful levels. And the thought is that perhaps there was, that there's this evolution that's happened, or coevolution that's happened with people in being able to get, or being able to have at least some exposure to the lower hertz. Now, 60 hertz is a low hertz compared to some of these other things that we're not even talking about, like Wi-Fi. I don't know about you guys, but if I looked at my Wi-Fi here in my office right now, I probably could log on to 20 different Wi-Fis. So I think there's something there, but it's quite controversial right now. So sorry we had to really burn through the last little part of that. Hopefully, if it interests you, you'll be able to go back and listen to it. I've got sort of down here at the bottom, I've got our sort of web address where you can look at the recordings. You can also sign up. The next presentation is going to be on October 3rd. Dr. Sharon Stills is going to talk about natural methods for detoxifying the biological terrain. So thank you very much. I'll just leave up here my contact information if anyone wants to reach out. Okay, thanks so much. If there are any other questions, let me know.